Monitoring oxygen saturation has become the standard of care in the ICU. With the proliferations of pulse oximeters, the detection of hypoxemia is much more common than we previously suspected. The difficulty of detecting hypoxemia on clinical exam is highlighted by this study that was done in the emergency department at UCLA. And what they did here is they monitored, patients were all monitored by oximetry, but the values were not private to the physicians until after they finished their assessment. Here you can see the frequency in which the physicians made changes either in the diagnostic testing or in the treatment when the SpO2 was available to them. And the changes seem to occur in patients when the SpO2 was 89%. It was less common at lower saturation, and it probably because at that level the physicians were able to detect for themselves the level of hypoxemia. The effect of episodic hypoxemia or desaturation was evaluated in this study in about 100 patients on a general medicine ward. And what they found is that hypoxemia was present in about a quarter of the patients. And interestingly, it was associated with a threefold increase in mortality when they followed these patients 4 to 7 months later. Now, this hypoxemia could just be a marker of the risk rather than the cause of decreased survival. But even when they corrected for the disease severity, they were able to still show that there was an increased risk of mortality with hypoxemia. So this study just highlights the need for monitoring oxygenation. And obviously the most common way we do it non-invasively is with the pulse ox. So how does it work? The pulse oximeter determines oxygen saturation by measuring light absorptions at two wavelengths, the 660 and the 940, the red and the infrared region. Now, the reason why those two wavelengths are picked is because oxyhemoglobin and reduced hemoglobin have different absorption spectra at these two wavelengths. In the red region, oxyhemoglobin absorbs less light than does the reduced, whereas the opposite occurs at the infrared region. Now, when measuring oxygen saturation non-invasively is limited because there are other things in the path of the light other than the arterial blood, such as there is the non-pulsatile blood, there is venous and capillary blood, and there are tissues. So the way pulse oximetry deals with this problem, it separates out the pulsatile or the alternating current from the non-pulsatile or the direct current. And then it just divides the AC over the DC for these two wavelengths. And then this ratio is then calibrated against direct measurements of arterial oxygen saturation. And then the resultant curve, the calibrated curve, is then used to generate the SpO2 values that we all see on the pulse ox machine. Most instruments, in addition to the digital readout, will have also a waveform display. And this will help the clinicians to distinguish a false signal from a true signal. Now, the accuracy of pulse oximeter has been studied in many studies. In the ICU, this was a study that was done by Lauren Bouchard's group, in which they evaluated its accuracy in a large number of patients. And what they did here is they compared the oxygen saturation with the pulse ox, or the SpO2, against direct measurements of oxygen saturation using the gold standard of a co-oximeter. And you can see here the bias, and the bias is just the difference between those two saturation, was pretty good. It was less than 1%, and the precision, which represents the standard deviation or the noise of the measurement, was less than 2%. Now, it's well known that the accuracy of the pulse ox decreases at lower oxygen saturation. In fact, in the study that we did, we found, this was in ventilated patients, that if the saturation was 90% or above, the bias was pretty good. It was about 1.7. But when the saturation goes down, the bias goes up to as much as 5. Another thing that can affect the accuracy is the probes. And this is a study, and they evaluated about 20 different oximeters with 20 different probes. And what they found that the overall accuracy was better for the finger probes than the ear probes. Response time is also different. And this is a classic study that was done by John Sebringhaus, in which he induced hypoxia in healthy subjects and observed how the different probes responded. And you can see that the ear probes responded a lot quicker than the finger probes in response to the hypoxia. Despite its popularity, pulse oximeter has several limitations. And this slide just lists some of them. Now, what the pulse ox is measuring is saturation. And saturation is physiologically related to oxygenation, or the PaO2, by the oxygen dissociation curve. The problem with pulse ox is that it's insensitive in detecting changes in PO2 at high levels of oxygen because of a sigmoid shape. So we know that in large changes in PO2 may occur with little changes in SaO2 on the upper flat part in the curve. For example, the 95% confidence limits of pulse ox has been quoted to be as 4%. If we take a saturation of 95, that could mean a PO2 anywhere from 60 to 160. Now, the way pulse ox measures, as I indicated to you earlier, it measures two wavelengths, the oxyhemoglobin and the carboxy. But there's the other two hemoglobins that exist, the methemoglobin and the carboxyhemoglobin. With pulse ox, it ignores these, or it assumes if they were present, they're insignificant. But in certain circumstances, these may be present a lot, and that itself can affect the accuracy of the pulse ox. Here I'm showing you the bias. This is a study in patients with carbon monoxide poisoning. The bias of the oximeter on the y-axis against the concentration of carboxyhemoglobin. And as you can see, that as the carboxyhemoglobin goes up, so does the bias of the pulse ox. And in fact, it overestimates the true percentage of oxyhemoglobin by the amount of carboxyhemoglobin present. Methemoglobin can also cause inaccurate reading. And here, as the methemoglobin was increased, there was a linear decrease in oxygen saturation, but SpO2 decreased, but then it plateaued at 85%. And beyond that, it didn't change. And the reason why that occurs with methemoglobin, it has to do with their absorption curves. For methemoglobin, it has the same absorption coefficient at the red and the infrared region. So if you have lots of methemoglobin around, what the pulse ox will assume that because they're both at the same wavelength, that it's a ratio of 1. And so this is why it plateaus at that moment. Nail polish. We've all heard about the story of nail polish. Here's another paper that was just published recently looking on the effect of nail polish in ICU patients. And what they found here, this is the bias looking at these different colors of nail polish they looked at. And what they found is that the bias was greatest for black, purple, and dark blue polish. But really, overall, the bias was less than 2%, so it was clinically not significant. False alarms, pain. This is a study in which they looked at all the alarms in the ICU, all false alarms in the ICU. And what they found, that almost half of them was due to the pulse ox. This study just looked purely at the pulse oximeter alarms, and what they found that in 3/4 of the time they were false in nature. And the reason why they were false is because either the sensor was displaced, motion artifact, or poor skin perfusion. And these false alarms were more common with finger probes than with ear probes. Motion artifact continues to be a big problem with pulse ox. Then in the late 90s, a new technology was introduced, the Massimo signal extraction technology, to try to extract the true signal from a noisy signal that's due to low perfusion. And what they found is that the pulse oximetry alarm frequency was decreased twofold with this system versus the conventional. But even more impressive is how it dealt with actual motion. Here are two examples. The top one is where a subject is just doing regular arm motion, and the bottom one is in a patient with a Parkinsonian tremor. The solid lines represent the signal from the pulse ox using this new technology, whereas the dashed line shows the conventional pulse ox. And I think you can appreciate that the spurious changes in the SpO2 were less with the Massimo system than with the conventional pulse ox. Now, low perfusion states can also lead to inaccurate readings. And here you're seeing the bias against oxygen saturation in patients who were getting vasoactive therapy. And some had shock, others did not. And the bias was more than 4% in about almost 40% of the patients. So it's clearly a problem in that type of patient population. Probably a major problem with pulse ox is that many users have a very limited understanding how the machine works and what to do with the readings once they get them. And in this survey, when they asked physicians and nurses, about a third of the physicians thought that pulse oximeter measures PaO2. Here you see on the right the lowest acceptable saturation in a fit adult, an SpO2 of less than 88%, which is a PO2 of less than 55, was considered acceptable by 27% of the respondents. So there's clearly a problem with knowledge with something as simple as the pulse ox. So what are some of the clinical applications other than obviously the detection of hypoxemia? Well, this was a study that was done by Tom East from Alan Morse's group, and what they wanted to answer in this study is, do decisions based on SpO2 mirror those based on the PaO2? Here you'll see the changes in PO2 versus the changes in SiO2. Values in the upper right corner and the lower left corner are going in the right directions for both sides. In the upper left, however, it means that the PO2 is going up, whereas the saturation is going down. And here is the opposite. The saturation is going up, but the PO2 is going down. And so what they found is about a quarter of the changes were in the opposite directions of each other. And therapy that was decided purely on SpO2 and not PaO2 was incorrect in about 16% of the occasions. We undertook a study to see, is pulse oximeter reliable in titrating the FiO2 in vented patients? And what we did is we adjusted the FiO2 until we reached 4 SpO2 targets, 90, 92, 94, and 95. Then we measured the PO2. And what we found, here are the 4 different targets I just mentioned, is that the optimal SpO2 target depended on the skin's pigmentation. And a SpO2 target to aim for when you're titrating the FiO2 was 92 for white patients, whereas black patients required a higher FiO2 of 95%. These investigators looked to see, is it helpful to monitor patients with seizures? Here you see the oxygen saturation in patients with seizures and in those with pseudo-seizures. And what they found is that desaturation occurred in 6 to 8 of the patients with seizures, whereas it occurred in none of the patients with pseudo-seizures. Is it cost effective? This is a very interesting study. And what they did here is they studied ICU patients in 2 periods. The control period was a year in which in their ICU there were only 2 pulse oximeters present. Then they compared that with an interventional period, which was 9 months later, in which there were now 12 pulse oximeters present for the same number of ICU beds. And what they found is that there was less frequent use of the ventilator and a slightly lower arterial blood samples when the pulse ox was fully available. Now, this is a very intriguing data, and if it does substantiate, what it's suggesting is that the routine use of pulse oximetry provided physicians with an early warning of a deterioration in the patient's condition, and led to the institution of measures that reduced the need for mechanical ventilation. And this is a study from Bill Sybil's group, again, looking at the cost-effective of pulse oximetry. And what they did here is they looked on the effect of implementing pulse ox in the ICU with staff education, but no formal guidelines. And what they found is that with pulse oximetry, the number of blood gases decreased by only 10%. So what this is saying is that without specific guidelines, pulse oximeters was used in addition to, rather than instead of, blood gases. So I just finished showing you how useful pulse ox. It measures oxygen saturation accurately, it provides useful information in various clinical scenarios, and it can even alter therapy. So it seems logical to conclude that all these useful effects should help patients. And in other words, it should improve the outcome. And forces are now moving healthcare towards a position that if an intervention or a device that has not been proven to improve outcome, we should just throw it away. So this was a study, the biggest study to date on pulse oximetry. It was done in over 20,000 patients in a randomized control trial asking the question, does the use of pulse oximetry decrease the rate of post-op complications? What they found is there was a 19-fold increase in the detection of hypoxemia with the pulse ox group, and myocardial ischemia was less frequent with the pulse ox group, but the primary outcome, that is their post-operative complication, did not change with the pulse ox. So the reason why they were unable to detect a benefit with pulse ox on complications, it has to do with the signal to noise ratio. The outcome they were looking at is MIs or deaths are very, very rare. So it would take a huge number of patients to show a reduction in these events. And in fact, the investigators did the math in their discussion, and they said to show a reduction in MI, it will take about 500,000 patients. To show a reduction in anesthesia-related deaths, it would take at least 2 million. So if technology is only useful if it's supported by a positive outcome, then this negative trial should have caused anesthesiologists to stop using the pulse ox. But in fact, when they interviewed the anesthesiologists right after the study came out, less than half says, yeah, this has changed the practice, and 80% of them still felt more secure using the pulse ox. So the fact that the Moeller was unable to demonstrate a beneficial effect with pulse ox at the P.05 level, P.50 level, but still, anesthesiologists still considers pulse ox a standard of care. To me, this mindset trumps the use of RCTs in looking at outcome when you're evaluating technology. So in summary, pulse ox is one of the most important advances in respiratory monitoring. And one of the two giants in the field of blood gas measurements is Severinghaus and Astrup commented that pulse ox was the most significant technological advance ever made in monitoring the well-being and safety of patients during anesthesia, recovery, and critical care. Pulse oximeters have a reasonable degree of accuracy, and the accuracy, together with the ease of operation, has led to the widespread use of pulse ox in the ICU. I think the major challenge facing pulse oximetry, whether it can be incorporated effectively into algorithms that improve the efficiency of clinical management in the ICU. Thank you very much.